everyone, and welcome. I'm George Grant from the Woodruff Health Sciences Center at Emory University. We are here today to draw attention to the intersection of health science with the spiritual health professions. I have a special moderator with us today, my partner, Chuck Raison, and let me introduce him. Chuck is the Mary Sue and Mike Shannon Chair for Healthy Minds, Children and Families, and he is the professor in the Department of Human Development and Family Studies in the School of Human Ecology at the University of Wisconsin-Madison. He is also a professor in the Department of Psychiatry at the School of Medicine Public Health at the University of Wisconsin in Madison. He also holds relationships with Emory University, not the least of which he is the Director of Research in Spiritual Health. Chuck, welcome.
Thank you, George.
And you're going to introduce our first presenter.
I am, and we're here. We had a little bit of a technical adventures right at the last moment there, and I'm so glad that I see all your smiling faces. So I am really happy to be doing this. It's a real honor to introduce our first speaker, Dr. Ellen Eidler. Dr. Eidler is the director of the Religion and Public Health Collaborative in the Samuel Candler Dobbs Chair of Sociology in Emory College. She's also joint faculty in the Department of Epidemiology in Rollins School of Public Health and a senior fellow at the Emory Center for Ethics. A lot of hats that are all big hats. Dr. Eidler received her BA in sociology from the College of Worcester and then spent a year studying at Union Theological Seminary in New York on a Rockefeller Brothers Fellowship, after which she received a PhD from Yale University in 1985 with training in both public health and sociology. So Dr. Eidler is known for her research on religion as a social determinant of health, health perceptions, disability, and quality of life, particularly with a focus in aging populations. Her current research interests and prospects include the role of religion in adult mortality as compared to other social determinants of health, religion's role in end-of-life decisions, the role of chaplains in palliative care, the impact of marital status on mortality following cardiac surgery, trends in suicide rates among middle-aged and older Americans, a comparison of patient-physician global ratings of health and primary care, patterns of religious practice in old age, and with a number of colleagues at Emory, the production of an interdisciplinary volume entitled Religion as a Social Determinant of Public Health, which was published by Oxford University Press in 2014. Dr. Eidler's research has been supported by funding from the National Institute on Aging, including a FIRST Award, the Fetzer Institute, the National Institute of Mental Health, and the Templeton Foundation. Her work's been frequently cited. She's listed as a highly cited scholar by the Web of Science. Her 1997 article on self-rated health and mortality was listed as the third most frequently cited paper of the decade by the Institute for Scientific Information. The paper has currently 7,000 citations. I was recently in a faculty meeting where a gentleman was coming up for promotion to full professor, and he was very pleased that in his entire career, he'd managed to get 6,000 citations. 7,000 citations for a paper is a stunning accomplishment. So Dr. Eidler, thanks. We're so glad you're here, and hopefully the slides will work and everything won't blow up, and we'll turn it over to you. Oh, you're muted, Dr. Eidler.
Keeping myself quiet. Well, thank you very much for that really kind and long introduction. I hardly know what to say. Thank you for introducing me, and I want to thank Dr. Grant for organizing this session. Dr. Grant and Dr. Lartey and I have worked together on the Religion and Public Health Collaborative since I first came to Emory in 2009, and I'm so pleased to be doing this new activity with them. So let me share my screen, and sorry. There we go. Do I get a thumbs up for you can all see my slides? Great, great. I think that the idea of people in religion and public health working together is an example of Emory's wide open interdisciplinarity and ability of people in different professional fields to work together. And so I hope that's a theme of this presentation, that it'll be about a specific event, but it'll really be about partnerships. So in the area of religion and public health, there's a long history at Emory that actually starts back at the Carter Center at a meeting that was held in October 1989 that was organized by President Carter and also Dr. William Faggy, who is pictured, the very tall person in the photograph with, as you can see, President and Mrs. Carter on the left. This meeting was a group of 200 interfaith leaders that focused on what they were calling the church's challenge in health, but it was an interfaith meeting. And President Carter, this is a quote from the report that was put out about it that means so much to us today, I think. There is no church or synagogue in America that could not coordinate and carry out an immunization drive against measles. So at that meeting in 1989, an organization called Atlanta Interfaith began, and that has become the Interfaith Health Program that is now in the Hubert Department of Global Health at the Rollins School of Public Health. John Blevins is the director of the Interfaith Health Program, and they work on projects around the world linking religion and public health. So I'd like to use my time to recount the history of the Ebola crisis, especially through the lens of religion's role in this public health crisis. Many individuals and organizations crossed this divide, and Emory is tied to this story in so many ways. So at the beginning of the crisis, and probably the first time that most Americans heard about the Ebola crisis in West Africa was because the American missionaries were airlifted from Africa to Emory University Hospital, and that was the live news footage from CNN of Dr. Kent Brantley leaving the ambulance and going into Emory University Hospital, which had special facilities that had been developed with the CDC for caring for people with this extremely contagious and dangerous disease. And so Emory was really there right from the start of people's awareness of what was going on. So missionaries were the first consciousness that we had, that many people had of this. So religion was involved right from the beginning. But religion was involved in another really important way in the crisis, and this is a report of the Morbidity and Mortality Weekly Report that that traced a cluster of Ebola virus, all stemming from the funeral of a very well-known and loved pharmacist in Sierra Leone. And you can see the many people who attended the funeral, and who were infected there. You can see this is the pharmacist, the index case, and then you can see people who directly got the virus from their contact with the victim at the funeral. And then you can see that some of those people passed the virus on to the second generation, and even here to a third generation. And many of these people died. If there was a D near their name, they were people who died as a result of this funeral. So funeral practices, burial practices, the traditional religious forms of burial practices in Sierra Leone were a significant risk factor for the virus. And this was known. Lots of studies have been done since then, but even at the time, they were very well aware that funerals were significant contagion events. And so a meeting was held at the World Health Organization to modify what were initially called safe burial practices, to have them take into account the needs for people to respect their loved ones. And so new guidelines were set up to develop safe and dignified burial practices. And as you can see in this press release from the World Health Organization, there was a big partnership with lots of international faith-based organizations, the World Council of Churches, Islamic Relief, Caritas International, World Vision. They got together to develop a protocol that in Geneva at the World Health Organization that would take into account and improve what were known, there actually, the phrase was used, the dead body management, to show much more of a respect and honor for those who were deceased, but to do it safely. And so protocols released in Geneva need to filter to people on the ground. And that was another key way in which faith-based organizations played an important role. So so shifting from being one of the biggest risk factors for contagion early in the outbreak, faith-based organizations rallied to help distribute these protocols and to back them, to give authoritative legitimacy to them. And so there's lots of organizations here involved, and I've got some sources in the bottom if you are interested in reading more about it. But one of the key things that happened was that an organization called Focus 1000 organized a meeting in Sierra Leone of the Interreligious Council. And Focus 1000 is a faith-based organization that was started by a public health specialist, Mohammed Jallow, who had a long career with UNICEF. He retired and went back to his native Sierra Leone and founded Focus 1000. Focus stands for Facilitating and Organizing Communities to Unite for Sustainable Development. It is focused on the first 1,000 days of a child's life. So this is a faith-based organization that promotes child health. And this group had in the past organized local religious groups, the Islamic Action Group and the Christian Action Group together. And so they had some networks of interfaith leaders. And they called a meeting, they convened a meeting together to develop messages based on these new protocols from the World Health Organization that would start having an influence on the burial practices. This is the other photograph here is Mohammed Jallow Jr., who is a CDC epidemiologist and son of the founder, but who also was involved very heavily in the meeting. And so they prepared materials such as this poster, Focus 1000's listed down here, along with other faith-based organizations to unite against Ebola. And here is a photograph from October 2014 showing what the new protocols looked like. There was not to be any direct contact of mourners with the body, but prayers could be said, and instead of black body bags, which were seen as very disrespectful, the shrouds could be white. And so this would allow clergy, an imam or a pastor to lead prayers and singing and to show the kind of respect for the deceased that they deserved. So these new burial practices went into effect in October 2014. The meeting took place all in October as well, and these messages began to be rolled out in November. If you look at this timeline of the epidemic, Sierra Leone is in the blue, and you can see has a very high peak here, and you can see that the peak is in mid-October and early November, and after that it declines. So this was a very direct attempt to address one of the most significant sources of contagion, and you can see that the effect was dramatic. So in April 2017 at Emory, we held a couple of days of an event to cover the partnerships in the Ebola crisis. Our speaker on the first day was Dave Robinson, who was the Muslim Christian interfaith relations leader for the World Vision Sierra Leone response during the Ebola crisis. World Vision is also a child-centered um, faith-based organization and had long ties with Focus 1000. And Dave was very involved in the response of World Vision to the crisis in Sierra Leone. And so, and then the second day, we had a number of different leaders of people who had been involved in it in various ways, discussing this. And so there was, I think, an attempt for us to, we held this over at the School of Public Health to inform people in public health about the really critical role that religious leaders had played. And at the panel discussion that was on the second day, one of the participants was Mohammed Jallow Jr., the CDC epidemiologist and son of the founder. And he told us that there was going to be an exhibit at the CDC's David Sensor Museum that ran from we had this meeting in April, but it was beginning in June and then ran through May for a whole year. It was a special exhibit about Ebola, the people plus public health plus political will. And this exhibit, right in the center of the exhibit, there was a quite large area devoted to the role of the religious leaders in changing the crisis. And so this display cabinet, I've got two pictures, the next one also, shows a Quran. And the Quran is marked with religious passages supporting Ebola prevention and control measures. And it says, this card in front of it says that this was presented to the CDC by the Islamic Action Group through Focus 1000. And on the other side of that exhibit case is one of the Bibles that was used at this meeting by the Christian Action Group. And Mohammed on the panel at that event told us that he knew about this display that was coming up at the CDC because he was going to be bringing this Quran and this Bible from Sierra Leone that had been used in the meeting. And you can see the post-it notes, the bookmarks, the underlining. This little phrase on the side here says quarantine, and it's marked next to a passage in Leviticus that refers to quarantine. So if any of you are interested in this, there's a great Facebook interview between Mohammed Jallow and Louise Shaw, the CDC curator of the exhibit. You can see that interview on Facebook. They're standing in the exhibit. And so that exhibit is no longer up, but they did a really big thing with Georgia State and Emory to produce a digital version of this exhibit, including the religious aspects of it and other things that the CDC did, of course. And that link is down at the bottom of the slide here at the cdcmuseum.org. It was just like you were there. In fact, they have lots of interviews with key leaders, including Mohammed Jallow Sr. And if you'd like to read more about it, we did a special issue of the American Journal of Public Health in March 2019 on partnerships in religion and public health. And Mohammed Jallow and John Blevins and Dave Robinson are authors of an article in that journal that was part of a whole set of articles on partnerships at state and national and global levels. And so the Religion and Public Health Collaborative is Emory's way of preparing our students in the professional fields of public health and religion to work in this space. It's a pretty big space, and it's one that's somewhat contested, but it is one that really relies on trusted partners. And the photograph here is of the last time we were able to get together. This was at the reception in fall 2019. And we had students who were participating in our dual degree program. Students can get a degree a dual degree in public health along with their Master's of Divinity or Master's in Theological Studies at Candler School of Theology. Some of the students were doing certificates, others were doing their MPH thesis. And so all of those students spoke very beautifully about their work across this intersection at Emory and the kind of career paths that they are looking forward to taking. And just to finish up, I'd like to thank some of the sacred work partnerships that are all around us at Emory. All of these people who were mentioned in my talk. I'm not going to read them all. So thank you very much for listening.
Well, thank you, Ellen. And we look forward to some question and answer period later. And the way our program is going to unfold now is that we're going to hear from Dr. Emmanuel Lartey, and then we hope to have some crossfire between you and Emmanuel and Chuck and myself. And then we will have a period of time for drawing from questions and comments from our worldwide audience. And so we look forward to that. I would now like to introduce the Reverend Dr. Emmanuel Lartey. He teaches pastoral theology, care, and counseling at the Candler School of Theology here at Emory, as well as in the Person, Community, and Religious Life program in Emory's Graduate School of Religion. Lartey came to Candler in 2004 and previously taught pastoral and practical theology at the University of Birmingham in the United Kingdom and at Columbia Theological Seminary in Decatur, Georgia. Lartey's research examines pastoral and spiritual care theories and practices operating in African, European, and American cultures. An internationally acclaimed scholar, Lartey is recognized as a pioneer in the development of an intercultural approach to pastoral care and counseling, which argues for and models respectful engagement across racial, gender, class, cultural, and religious boundaries. His book, 1997 book, In Living Color, An Intercultural Approach to Pastoral Care and Counseling, now in its seventh, I think it's a second edition, or is that correct? And the second edition is internationally used as a textbook in pastoral care. And when I've come into pinch hit for Emmanuel in coursework at Candler, I often use two of his books. One is right behind my head over here. And so Emmanuel, we look forward to hearing from you, and you take it away.
Yeah, thank you very much. I join you all. I join Ellen in saying thanks to you, George, and Dr. Raisin as well, and all of us for the work that we do together and the work that we have done together over these many years. I'm going to share my screen now, and let's see if yes. So the first that I come to this with this sense of collaborativeness, this sense of shared commitments to certain things that I think we have in the scientific, the religious, and the public health and other health sciences. I would want to even describe what we have as a reverence for truth in all of these disciplines, a reverence for life, and a commitment to study. And it is that which I find to be fascinating and the basis upon which a lot of the work that we do, the interdisciplinary work that we do at Emory and across the world is based. It is where we have a recognition that each of these disciplines is really sharing this kind of sacred commitment to truth, to life, and to research and study. Perhaps there's no better current example of someone who adheres to the values of both science and religion than Francis Collins, who last year won the prestigious Templeton Prize. Francis Collins was appointed 16th Director of the National Institutes of Health by President Barack Obama and confirmed by the Senate. He was sworn in August 2009. In 2017, President Donald Trump asked Dr. Collins to continue to serve as NIH director, and President Joe Biden did the same. Dr. Collins, therefore, is I guess, the only presidentially appointed NIH director to serve more than one administration. And we recognize the many ways in which Dr. Collins has made significant contributions to scholarship in medicine and in the sciences, winning presidential medals of freedom in November 2007, receiving the National Medal of Science in 2009, and then being elected as the foreign member of the Royal Society in the United Kingdom. And as I said a moment ago, winning the Templeton Prize last year. Francis Collins is also a born-again Christian and has written about his path from atheism to faith as a medical student when he encountered life and death on a daily basis. And so he represents if you like, a real confluence, a happy kind of working together of religion and faith. But it is also quite clear that not all religion and not all religious and spirituality serves the purposes of health and well-being. We are all witnesses in these last few months in particular of where religion has been harnessed to kind of achieve really very, very nefarious goals and aims. We also are aware of the conflicts that have played out. There have been areas of a lot of collaboration and a lot of working together in the COVID-19 situation, but there's also been conflict. There's also been areas where there's been challenge and pushback and so on. And it serves us well if we, in our study of the relationship between particularly religion and health, it serves us well if we actually engage more closely in examining some of the pushbacks and some of the things that militate against collaborative work among us. One of the crucial tasks of the discipline of theology, a task which lies at the heart of our theological studies, whether it is for the purposes of training chaplains or training ministers and those who will serve as leaders and so on in the church. One of the crucial tasks of the discipline of theology is a critique. It's a critique of the symbols and the practices of religion. You see, our study of theology is not narcissistic or solipsistic. It's not a kind of navel-gazing, self-congratulatory approach. It is one that seeks to be critical and to be research-based as we engage the symbols and the practices of religion. So in that respect, I want to mention a colleague and friend with whom I have done a lot of research, a practical theologian by name Daniel Sipani. He's a psychologist, a licensed psychologist, as well as a PhD from Princeton, and served for many years in Anabaptist Mennonite Biblical Seminary as professor of pastoral care and counseling. And Daniel and I have worked internationally with the Society for Intercultural Pastoral Care and Counseling based in Germany, the International Association for Spiritual Care based in Switzerland, and the International Council on Pastoral Care and Counseling. I particularly am attracted to some of the views that he has about what the church is called to be, and especially some of his views on what practical theology involves, a contextual and committed reflection on the life and ministry of the church and on the processes of formation and transformation of persons, families, and communities. And I completely find myself in sync with this engagement that he describes in the endeavor that lies at the intersection of the disciplines and the fields of study. One of the things that Sipani has been principal investigator on has been an exploration of religious communities, various religious communities, and in exploring the nature of the spirituality that is adduced and that is practiced. The term toxic spirituality is one that Schipani, well, it's one of his originating ideas. And what we have found in some of these studies has been some of the characteristics that are associated, that is the religious characteristics that are associated with far more of a combative than a collaborative approach towards especially the health care. So among the characteristics we find is this rigid narrowness, an impairing of a humane spirit, a kind of dogmatism that speaks of faith in absolute certainty terms, rather than recognizing that faith itself presupposes an appreciation or a capacity to deal with paradox. And so these are some of the characteristics that are associated with some of the less, if you like, the less palatable manifestations of religious practice. Also, and I'm just summarizing in these slides, summarizing some of these characteristics that have been unearthed as we have studied religious communities. The inclusion of always a measure of violence, the authoritarian leadership, the undermining of emotional and mental health. Some of these are present in all of these. And so again, we also find when we study faith in these communities, when we study, we recognize that there are people associate with faith a particular kind of dogmatism or a particular kind of denial. And on the other hand, we find that there are those for whom faith manifests itself in an openness to mystery, complexity, and plurality. When we look at when we studied hope, we studied faith, hope, and love. These are characteristics or tenets that various religious traditions hold dear. again, you found people associated with a hope, particular kinds of things that I have characterized as negative or positive in this kind of way. And then we also did the same with love, and it was interesting to find the ways in which some people talked about love in terms of exclusivity, even enmity, while others saw it more in terms of communion, multiplicity, and so on. So what we have tried to do in all of these is to really explore lived religion and explore some of the ways in which people associate some of these particular tenets of faith to the ways in which they live out their lives. I want to end what I have to say by making reference to a center that we have recently been involved in partnership with an educational foundation that is Martha Educational Foundation, based here in the US and also in Ghana. The establishment of a center for mental health, neurological, and substance use disorders within an African context. And I have been involved in the development of this and the development of a particular treatment or therapeutic model that seeks to be contextual in recognition of the religious and cultural specifics of the patient population, that seeks to be humane in being mindful of the rights of persons embedded within social and communal kinds of societies. And that seeks to be integrative in the pooling of professional resources in the treatment and the education of persons in these situations. And so we have come up with a model of approach that is being engaged and practiced in this center that has just recently, in the last 3 years, come into existence. And we are on the cusp of studying closely the effects of bringing together in the treatment of persons a very, very collaborative kind of model, one that reflects some of the ways in which chaplains are trained and work in contexts that Emory is associated with. So part of the and every patient has these 4 professional groupings to be present in their treatment: the psychiatrist, the psychotherapist, the nurse, and the spiritual care provider. And I just highlight particularly the spiritual care provider. We are also in the process of utilizing that facility as a place where we can help to develop and strengthen the spiritual care providers who are in the African context traditional priest healers, and who were the people who provided mental health treatment, which was studied and which the WHO study on mental health treatment exposed as woefully inadequate and woefully deficient in terms of being humane or being in any way actually reflective of the what is best in terms of mental health care and treatment. So in this center, we are providing an opportunity for spiritual care providers from a range of different religious backgrounds to work together and to actually learn from some of the professionals who will respect the contributions that they bring into the mix. And so that's just an example of our ongoing attempts to be contextual, to be humane, and to do integrative work between the different professions. And I will end with that and turn it over right back to you, George.
Well, thank you so much, Emmanuel. What a powerful model, and something that I think we can all agree that the multidisciplinary approaches are that which are more effective. And we're certainly doing things in the healthcare domain of like nature. I mean, an example of that is having Dr. Chuck Raison as our director of research, and he covers a vast amount of work just in terms of researching interventions that are evidence-based. And so we're more and more turning toward this intervention type of work. I'm going to change our view now so that the four of us are up. And we've had some very interesting chat going on in the Q&A. A lot of folks are wishing others well and noting where they're coming from. And we've had some excellent comments, but we're going to turn to those in a little bit. I did want to perhaps kick us off, the four of us, to turn to something that we have touched on already today in your two presentations. And that is a word that's sometimes bandied about in US culture of recent time, and that is tribalism. And, you know, the powerful forces of, you know, belief and how people pull themselves together from disparate areas to become a solid force, some for ill will. And we've certainly seen that represented in, you know, the violence that we've experienced over the past year. And, you know, we've had plenty of that on top of the violence done, you know, to our health. So the two have commingled at times. There have been conspiratorial forces that have certainly shaped our health course. So I'm wondering if we could, if we get Dr. Idler and Dr. Lartey to comment on some of that kind of force that we're exposed to now.
Well, my immediate reaction to that would be that in the public health space, definitely in the story that I told, but in the entire history of the Interfaith Health Program going back to the 1980s, it's the interfaith part of it that's really critical. It's when different groups are working together to understand what their common interests are without setting aside their individual beliefs and practices. That's when you get really powerful movements, is that the partnerships are where people recognize what they have in common with each other without setting aside their differences. And so for example, at the meeting of the religious leaders in Sierra Leone, the Christian Action Group and the Islamic Action Group prepared messages and sermons and teachings for their own communities. They weren't saying the same thing to their own communities, but they were working together out of a shared space to understand the challenges that they had. Certainly the funeral practices would have been different for those groups, but they were able to preserve their particularity at the same time that they understood the common good.
That's a little bit unusual in my experience. I mean, sadly, right? That's, was there something about Sierra Leone, something about, I mean, there's two things that strike me. And one was just a comment from in the chat about, you know, where were there groups that were opposed to this attempt to sort of find a way to marry, honoring spiritual practices with public health practices? How was it that that the faith leaders? It seems like as long as the needs of the spiritual heart of the people could be accommodated, a compromise was possible, right? It wasn't a do or die, all or none kind of thing. Why were there unique situations on the ground? I mean, if we look, George, to your point, if we look at what's going on in the United States right now, we're not seeing so much of that, right? We're seeing very often people have such diametrically opposed starting assumptions that there's no going there, So what was it about that moment? Was it just that Ebola was so horrible that nobody worried or contested that there was an issue at hand, or what was it?
Not sure. Did you want to talk to Emmanuel or to me?
No, I'm just curious in general. Talk to anybody because it really is fascinating. Ellen, you said you talked about it. Why don't we start with you? What was it about? What was the secret sauce?
Well, I don't know that interfaith or ecumenical projects are new or particular to Sierra Leone. This just happens to be a really dramatic one. But when the civil rights movement in the United States had a profound foundation of interfaith groups. Now, I think that it's, and I am not a theologian, so I might be getting wrong here, but it does seem to me as if religious groups with large organizational structures, with regional and national organizational structures, are possibly more likely to be working with each other across groups. The National Council of Churches, for example, in the United States, is going to represent all Protestant groups, and so they have channels of communication. But yeah, the Interfaith Health Program started long before Ebola. So this is just one illustration of how groups can work together. But in that context, it was really important that, in the middle of a crisis, that those networks and the familiarity of those religious leaders with each other, because of their past projects and shared activities, formed a foundation of trust and a willingness to work with each other, because they were known partners to each other. And so they were more quickly able to get to the common shared ground to work on this project together.
I think also, I think that's the case. But there's a history of collaborativeness, but and this is, like in Liberia, just next door, Liberia, with the rise of the warlords and all of that, which happened. It took women's groups that came together, Muslim and Christian, praying together because of the horror of what was happening. That really kind of like generated a sense, as somebody said, the bullet does not distinguish between the Muslim and the Christian. So, I mean, if we are committed to life, then we surely should be working together, and can be working together to promote that which brings for life. So I think that yes, the severity of the crisis, but also the recognition that that combat is not the best way to deal with situations of difficulty and crisis. And if that combat is coming from the religious sentiment, then that is particularly egregious, and so that was a recognition on all the sides, and I think that has continued to happen, in other places as well.
Some of the conversations that you, Ellen, and Emmanuel and I have had through the years is this traverse across population health and individual health, and how the two come into relationship with one another. And I heard in the model that you were describing, Emmanuel, this marvelous sense of, it felt like a marvelous sense of community that was ushering in, that real privilege of being with an individual in their pursuit of health. And I'm wondering, what are those those kinds of properties that keep us engaged with understanding how much of one and how much of the other keeps us on track with regard to general public health concerns.
I think that I would lift up the sense of respect that I think, and this is both disciplinarily, you know, a kind of, I think that where there has been, you know, say for example, between the religious and the professional scientific, where there has been a kind of attitude that says, you know, one is destructive to one's health, and the other is nothing but good for the where that attitude, and so then a sense of disrespect for what the other may be bringing, then that really is the thing that militates against any kind of collaboration. And that's a huge hurdle, you know, getting into the place of mutual respect. I mean, it's not only between the disciplines, but also between the religious traditions, you see. So it's a huge, you know, it's a huge endeavor, but it's one that when one can point to some of the common values, you know, so that's why I began with a sense of we all share a reverence for truth. We all share a reverence for life. We all committed to studying together, learning together what works best. These are things that, you know, when I sit with traditional priest healers, as I've done in my own research, you know, I have gone with an attitude of I respect what you know and what you have, you know, and what can I learn from it? And this you know, the knowledge base, the for example, the herbal thing and so on. It's actually been captured in studies in university. Kwame Nkrumah University of Science and Technology in Kumasi has a herbal medicine degree, which is based in the pharmacy department, you know. So there's a developing sense of let's respect the knowledge bases that are there. And then out of that can come the critique of where its you know, inefficiencies lie, and its improvement that can result. So I think it's very important.
Go ahead. Did you finish? I'm sorry.
Yes, I think I was just saying, I think respect between the professions, respect between the practitioners is very, very important in the development that we're looking at.
Well, one of the things we've struggled with in the past years is information and disinformation.
Right.
And Ellen, I'm wondering, you know, in terms of your survey of the global health experience, how do the organizations, the faith-based organizations and the NGOs, how do they get the information from the religious circles and the spiritual forces that account for health?
Say a little more before I get a good idea about what you're talking about.
Well, I'm wondering if there is an infusion of religious ideologies and faith tradition experience and spiritual knowledge that helps the organizations come into this respectful relationship that Emmanuel's referring to on the ground.
Well, I guess, common ground of people in various religious traditions across the world is one of compassion of one of understanding our humanness and our common respect for each other. So with that sort of starting point, people can, I think, move together and to find the ways that they can work together. I mean, people's differences are not going to go away or be explained away or argued away. The key is to have people understand what views they can have in common so that they can work together on parts of problems. They might not tackle the whole problem. They might tackle the part of the problem that isn't in conflict with their religious beliefs, but is a way of constructively moving forward. And I think that's the key to everything, especially, so you're talking about between religious groups, but between religious groups and public health, for which there has been, you know, some considerable antagonism, especially over reproductive rights, for example. The key is really to finding the common ground. And so that was one of the reasons we named that special section about finding common ground. That was, it's an art. And people have to be willing to show the compassion, to put in the work, to find where their interests align. And so there has to be that motivation, I guess, to look for the alignment. But there's some alignment. People can find alignment if they're looking for it.
And, you know, so I got a question. So I mean, I'm really struck by, again, sort of a contrast between, Ellen, what you described in the Ebola thing and what I've seen a lot of in the COVID-19 sort of experience that we've had as a nation, which is that the differences within religious organizations may be greater than the differences across religious organizations, right? So if you took folks, say, within the Christian camp and looked at the sort of extreme positions, you find they're really kind of antipodes to each other. Do you know, is there work sort of in trying to find that even if it's a postage stamp sized bit of common ground in sort of the COVID moment between, say, you know, the more traditional, larger scale religious organizations, which perhaps blow a bit more liberal and a bit more in support of scientific understandings, and this very, very large contingent. Many of the people that I've grown up with are on such a different side of a fence that finding the starting point is a really interesting question. Can either you or Emmanuel, what do we know about what's being done in this domain of sort of now within faith dialogue to try to bring these things together in this public health moment?
Well, I think the new survey data really does show, for quite specifically, and this is survey data from yesterday, the Kaiser tracking poll, that the most vaccine resistant group in the United States is white evangelical Christians. Of all the groups, about the same as Republicans as a group. So yes, there are certainly differences within Christianity, and the evangelical churches are going to be a lot more conservative than the mainline, more liberal groups. And so I've been working on a project with a couple of other people at Emory on representations of religion and COVID and in the news media and by religious groups themselves. And it's really been quite fascinating. The media tend to want to see the negative and the contrarian, and and there's plenty of that, not just among Christian evangelicals, but here in the New York area, and a lot of the local news has been about the ultra-Orthodox communities in Brooklyn and Williamsburg that were holding huge mass gatherings and not abiding by mask mandates at all. The representation of religious responses to COVID in the New York Times, this was our study from the first 6 months of the pandemic, was really pretty negative at the beginning, according to text analysis that we've been working on, but trended more positive. And when we looked at the sites of the religious groups' statements about COVID or the guidelines that they were putting forward for their communities, they were uniformly following WHO and CDC guidelines. Now, you know, individual churches might not have been, and maybe what people put out on their websites is not what they actually do. But certainly the representations of those religious groups themselves on the web was to be very much in line with public health guidelines, and with using virtual worship services rather than in-person ones, and masking and distancing and all of the other recommendations. So the trend in the New York Times articles was quite negative at the beginning, and then trended more positively towards the end of June, which is when our series stopped. And that was quite interesting, and then became undifferentiated from the representations on the religious groups' websites.
It's interesting that at once we have science under attack, as well as religious traditions under attack. So finding that, as Chuck said, the postage stamp, is a critical challenge. One of the pieces that we've been working toward here at Emory is working on that word, compassion, that you spoke of, Ellen. And we've been working with the Center for Contemplative Science and Compassion-Based Ethics in order to understand a worldview inclusive understanding of relationship and how we can locate the postage stamps. But I sometimes sense that there are folks that don't really want there to be a watered down experience, from, their spiritual concerns or the religious concerns. So we've been jostling in our development of interventions around the respectful pursuits of an individual and their historicity, and that which they find comforting, as well as some understanding of how others are experiencing the world as being helpful to that person, and in a way that is expansive. So I'm wondering, Chuck, you and I have been in this world in terms of studying and also researching these types of interventions. But I'm wondering if your sense of it is, my appreciation for you, Emmanuel, is that you have this a healthy attachment to the persons and respectful of their traditions. There was one comment earlier in the chat about being careful of labeling toxicity and labeling what is healthy. And we've been trying to define that which is spiritual health here at Emory. But, some of these labels can come under,
Yes.
Vast criticism.
Absolutely. And, coming to the description of something in terms of spirituality as toxic was one that I had a great deal of emotional and developmental crises about. So even categorizing some of the work we were doing, categorizing certain things in the ways in which we did. So I do not use the term toxic spirituality without a great deal of emotional and other angst. So it's not my preferred term. But in terms of a way of really looking at what was happening, and in terms of research, nuancing what was being said, but also seeing some of the effects out in the ground. I mean, when certain practices and certain beliefs lead to huge mental health challenges, or they lead to actually harm and destruction of life, then one cannot but say there's something toxic about this way of thinking. Many years ago, the Jim Jones situation, it was the result of religious kind of thing, and nobody will say that was not toxic. You see, so it's that kind of thing that that drives one to
Mhm.
and but having said that the thing is toxic does not then mean that one throws everything out. What we've been trying to say is look with critical eyes at one's own faith practice, and I mean, I like many of us, I'm deeply involved in the communal life of a faith community, and teach regularly, preach regularly, So,
Mhm.
some people have spoken about unhealthy religion. Some people have spoken about, um, the thing is, one needs to be able to come to the place of recognizing toxicity within oneself. And then one is able to, to engage with others. And our study was across religious traditions. We looked
Mhm.
different, and so it wasn't one religious group saying that the other was, but it was each coming to a sense of there are elements when I hold this, when I faith, to use Jim Fowler's way of thinking. When I faith in a particular way, there are certain results, and these results may be harmful, and so if these results are harmful, then I need to look at the nature of the faithing that I do, whatever the belief structures might be, whatever their content might be.
Mhm.
What we were looking at is, how does faithing in this particular way, what does it produce in
Mm.
terms of mental health, in terms of relational health, social health, and so on. And so I think it's got a lot of relation with outcomes, and so on. So that word, as I said, is where that is coming from.
Ellen, with the dual degree program at Emory, the MDiv MPH, and also the certificate program, I'm wondering if any of the past years now have influenced the direction and also the curriculum of those programs. What is changing? We have a lot of folks flooding now toward the public health schools, and I'm thinking, that the schools of theology are making adjustments too on how to be prepared, for quote unquote the market. So I'm wondering if you're experiencing any changes or any expectations.
Oh, that's a great question. So I would say that my own understanding of this, I think, may parallel that of the way we've been thinking about religion and health. So, my dissertation was on religion and health, and I absolutely thought of it at the individual level. I thought about individual people's religious practices and the impact that would have on their physical and mental health, especially older people. And there was a beneficial effect of the social participation in and religious attendance and the participation in religious groups. And I'm a sociologist, so it was the social dimension that was really important for individual health. And it was individual health at the population level. Those studies were representative of large populations, and there are many of them all across the world, not only in the United States. But that's only one level of thinking. That's the level of thinking about the individual and individual outcomes. They're done on the basis of surveys with people who report about their religious participation, and then they get tracked over time, and you see what their health outcomes are. But I think at Emory, there's just been a growing understanding of stepping from that individual level, that individual participation effect level, to the level of organizations, and how organizations interact with each other and can move mountains. So it isn't really just about changing individual lives, although there's nothing unimportant about that. I, studied it for years. But the idea of moving to the way we need to work with each other within organizations and between organizations to accomplish large goals. Individuals don't accomplish large goals all by themselves. They have to do it with others, and they have to do it with others who not necessarily come from the same place that they do. So I think that in public health, there's a growing trend towards people working in groups with each other instead of just on individual projects. They don't just write their own paper and then, get their own grade. They have to work together with groups, and people in groups bring different capabilities and motivations, and that's life, right? We have to learn to work in groups. So I think that idea of group work and understanding group processes and understanding organizations' powers and structures are really an important thing that we can give our students. And that's on both sides, right? We're talking about two professional schools where organizations are incredibly important, and they structure our own individual experiences.
Mhm.
Chuck, what are you hearing on your end of things?
I'm really looking at the chat. Somebody should publish a book about the chat, man. It's just, I'm watching Emmanuel. He's looking at it too. It is really, well, you talk about groups, right? So we got like, people all around the world that are weighing in here. And I mean, clearly we've hit a nerve with this sort of question about, positive and negative spirituality, and it's something I'm interested in. I'm going to throw my 2 bits. I was thinking about this morning. I'm an adherent of science. I confess to that perhaps being my religion, if I have one, which is a limitation also. But one of the things that's useful about science is it's one of the ways that people can actually come to an agreement with each other, which is really quite an accomplishment, right? It allows you to frame questions in ways that if you frame it right, and you can actually get a replicable answer. So, you may think that A is true. I may think that B is true. If we set it up right, and if we agree, that if it goes this way, A is right. If it goes that way, B is right. And, if B is right, and then, you say, well, I don't believe that, I'm going to do it again. And you get B again. This is, you can develop these sort of agreed upon semi-bedrock, sort of operational truths. And this is where I'm kind of interested in the intersection of science, religion, and George, what you and I've been looking at is it's modest, but yet it's kind of profound. Can we take a spiritual practice, in this case, how the clinical health, the spiritual health clinicians are trained, and can we apply scientific methodologies to try to understand what works and what doesn't work, and can we improve what works? How do we bring, are there ways to optimize bringing, the universal human spiritual sort of drive into healthcare? How can we do it? So, I mean, I think this is one of the ways. There was a comment that I saw that I understand and I agree with. They said, well, for all the sort of bashing of science that religion does, science is even uglier than bashing religion. And this is often true. There's a terrible arrogance there, and one of the powerful things, Ellen, about your story to me was, as long as they were just saying safe burials, they weren't getting anywhere. They were being non-scientific. Actually, they were underestimating this hardcore evolved human cultural thing. And if you didn't take that into account, the car wasn't going to move. And as soon as you take it into account, boom, off you go, right? That's a way that I think science can sometimes help, is try to help us understand, can we identify things that we do agree on are basic core values? And if we can agree on those, like that it's better to be healthy than to be sick, or that it's better to be happy than to be depressed and miserable, then, even if it's just a postage stamp there, we could explore ways to, say, let's look at this and agree upon, if we do this and if we see this, that we've got, maybe I'll have to change my view, maybe you'll have to change your view. I mean, one of the cool things about science is, every single theory I've had has been wrong thus far, and it's kind of a good thing because the world's a lot more creative than I am. And I think that's something that science can bring to the spiritual sort of world also, is the freshness of that large universe in which we're in. So So anyway, so just looking at all this, these are such great comments, and clearly, I commend you, George, in pulling this together to tackle something. I mean, this is at the heart and soul of a lot of angst in our country right now, and if we don't address it head on, ignoring it is I don't think it's going to get us there. So it's really good that we're having this conversation.
Well, and the work of categorization, Chuck, in terms of how we're understanding linguistics, for instance, very powerful software programs right now, and understanding the type of words that are more comforting than others and show a real efficacy toward health. I'm enamored with language and the power of developing, these conversations that you cannot begin to commingle unless you're actually talking and listening. So in just our pursuit today, the goal was to get together here and to have this conversation that would necessarily invite us to shape a conversation that can kick the ball down the field. And so we're going to continue to do that. I feel like this is the mission of spiritual health. And I'm just delighted of how things have gone so far. So we don't have much time left, but I would want that Ellen, you and Emmanuel have perhaps some final thoughts about what you're hearing, of what you've seen in the chat. And it's virtually impossible for us to answer all the questions.
Hopeless, but it's just cool to read it, man. We gotta publish. I wonder if we could sort of collect all this and put it on a website for people to have who participated.
We're gonna have to find a way. And,
this is just killer.
Yes, I'll try to do that.
We should meet 4 times a year. I like that.
I mean, I think that could really be one of the outcomes of this gathering, if it could promote smaller group discussions among our 600 registrants. I mean, if people might or we might in some way facilitate conversations, because this is but I think the beginning of a very, very, very fertile possibility. I mean, one of the things that I'm not about minimizing or destroying anyone's religious sentiment or fervor. What I found really is the more I go into my religious tradition and I study more and more of it and become exposed to its vastness and its dimensionality, I begin to realize that there's far more than what I held on to as being nothing but. There's far more, So I'm actually deepened. I'm actually strengthened by the fact that there's a vast array of differences on any of the things that we hold. So if you're a Muslim or if you're a Christian, within your own tradition, there's a whole lot of difference, and so maybe your allegiance to one particular bit of it is not, maybe maturity will cause you to see it more in its breadth and its vastness. So I really do think that if we could have these kinds of conversations in our professional groups, in our religious groups, we might, kind of like have some more to contribute to each other.
Marvelous.
Well, I'd like to just come back to the title that George came up with for this, and that is the idea of sacred work. I come from the Presbyterian Protestant tradition, and so it was really important for Christians in the Reformation, listening to Luther and Calvin, to start seeing work as a dignified process. You didn't have to be a member of the clergy to be doing sacred work. And I think that we're talking about all kinds of sacred work that people do with each other. And if we can improve our understanding of the care with which we treat our work and the seriousness with which we go about it, we'll be doing a lot to enhance collaborations between people who are coming from very different places. Public health and religion, these are two schools that don't talk to each other very much at most universities, but by getting students together in classes with each other from these different schools and having them work on projects together, I think people start to get an understanding and a perspective sharing that really is a really important sort of tool that we're going to be sending them out with. So kudos to you, George, for coming up with the theme, because I think it's a really important one that summarizes a lot.
Well, and thank you for both you and Emmanuel and your expertise in this domain. We're just so fortunate that we have local talent that we could touch and get out the door here. And I really appreciate your involvement. Chuck, from a medical scientist, physician scientist viewpoint, the sacred underpinnings, as I like to refer to it, sacred work. I mean, it's vocational, right?
Oh yeah, absolutely. I mean, it is a calling. I mean, it's more, it's really more than a job, and trying to understand, how these things fit together and how we can leverage these things to optimize our ability to appreciate this really astounding, wonderful world we're in. I mean, to me, that's nothing interests me more than that. It just seems to be one of the great sort of challenges ahead of us. It's just really interesting. I got to say, the four of us have been talking here, and I think in many ways, much of this meeting was in these texts, and there's a wide range. There's people that were offended. There were people that were pleased. So I mean, we've done a little science experiment here of a sort where we should really go in and look and see and engage with the folks that it'd be fascinating to explore all the different sort of things that were articulated. You can see them sort of flow through here. I do think what it speaks to, and this is my bias, as somebody said, we're all trapped by our worldviews. Whatever the ontologic reality of spiritual desires are, the fact that human beings as evolved beings in this world, in general, have this strong drive towards the spiritual, towards the sacred, toward the sense that there's a meaning and a purpose, and that we're driven to pursue it. That, we can spend all day talking about why we have that, but that we have it, and that it's essential to health. I personally think that's not debatable. And so trying to bring a scientific understanding to that while fully honoring it, I think this is one of the great intellectual challenges in healthcare right now. And so, this is why we're so lucky to have the opportunity to work in this space.
And you often talk about the human face of medicine.
That's
and
right.
Making sure that the relationality and a person's values are respected and revered.
Absolutely.
And that's something that we've been challenged with, in the masking and the PPE and a lot of the anger associated with, why aren't we over this? And it's been really a tough time, and my heart goes out. Blessings to all those who have suffered over the past year and a half with the pandemic, but also the violence and the hatred that we've experienced. And it's really been a challenging era. But I want to thank all the participants and attendees who joined us today. And there were a lot of folks that are, sleeping and hoping that they'll get the recording. And so we will get the recording out.
Good.
And we will start this forum. It's a good forum to have.
Okay.
And I may even call it the forum. But I'm well pleased, and we will invite you to come to our website for some content, and we hope to join with others and multi-site investigations, and so more to come. But you can follow us at spiritualhealth.emory.edu. And I want to thank everyone for attending today. And thank you, Ellen. Thank you, Emmanuel. And thank you, Chuck.
Oh, my
Really
pleasure.
appreciate
Yeah,
this.
thank you, George.
Thank you.
Bye
All right.
now.
Bye now, everybody.
Thank you.
Thank you.